and pain without any corroborated clinical signs or objective investigations. So are these diseases rare? No. I mean, it depends with what eye we look at them. So basically, it's a problem. My thing is going fast. Yeah. So JIA, all these diseases are very much present in our community, and it's up to us to pick them up. So JIA has a prevalence of 1 per 1,000, and SLE 20% commences in childhood. KD is quite common, especially in your area, Kasaragod. HSP is also common. So the first thing I want to come to introduce you to is PGALS. PGALS is a very, very simple evidence-based screening tool for examining the joints in children. Okay, and it's basically, GALS basically means gait, arms, legs, spine. And it's very easy to do and very easy to interpret and doesn't require any infrastructure. So the PGALS screen involves, basically you get the child to walk, observe the child walking and turning, and that can bring up a lot of findings in that area. I'm going to rush through it. I'm just going to show you because this is free available on YouTube. You can actually go through the process very clearly. And the arms, the outstretched arms, twisted arm, pointing index and the first finger, then squeezing the metacarpals, making a prayer sign, an inverse prayer sign, and looking up while you lift your arms right above and putting the arms behind the head. Okay? So each of these is actually self-descriptive. Then if the child can't do it, you will actually see the difficulty directly as you do the test. And for examining the legs, you need to get the child to lie down and you examine each of the joints separately. This is the first picture is showing how you look for a knee effusion. And this is again checking the various movements in the hip and the knee. Similarly, internal and external rotation of the hip. And then this is a temporomandibular joint, which is involved much more in children and can actually cause a receding chin if it's not picked up. And similarly, examination of the spine, the cervical spine looking up, looking sideways, examining the child from front, back, and the sides to look for spinal deformities, getting the child to bend forward. Examination is not complete unless you look for enthesitis. Enthesitis is basically where ligaments and tendons attach to bone. So these are the various points, the iliotibial tract, the gracilis, Achilles tendon, the plantar epineuritis, around the quadriceps, etc. And usually when children have enthesitis, inflammation of these enthesial points, the arthritis that accompanies enthesitis usually involves the lower limb. And the key to them, other than the ankle and the knee, key to them is the. So basically, when you see a child with joint pain, what are the simple things you need to do? Before you do a detailed history and examination, you check whether the child has arthritis or arthralgia. Arthritis and arthralgia are not equal. Arthralgia is purely symptom and arthritis is actually objective. How long is a symptom going on for? Is it acute or chronic? And 6 weeks is our usual cutoff. Is it a single joint or multiple joints? And is the joint pathology the only problem the child has, or the child also has a systemic illness present? So that is, and then this is how you put together your pattern recognition. So as we went through that, there is a huge spectrum of differential diagnosis. That's why JIA is called juvenile idiopathic arthritis. So you actually have to think of so many other things while you are diagnosing a child with JIA. So let's just look at one example of pattern recognition. I'm going to show you 5 children, all 3 years old, with the same kind of symptom and 5 different diagnoses that they had. So here is a 3-year-old boy who presented with an acute onset of pain and right-sided limb. He was systemically well, there was no history of trauma, and he had a viral infection a week ago. And clearly he had a limp and a tender right hip. If you look at his investigations, they don't look particularly concerning. There's a very slight ESR elevation. And this is the kind of child who has a tender right hip, but no other major problems. And this is likely to be a transient synovitis of the right hip, an acute presentation. This is another acute presentation, but this child has high-grade fever for 4 days, is toxic looking, and has a right limb, right lower limb limp. And she has a pseudo-paralytic posture when you see her. She's very tender and she completely doesn't let you examine. But you look at the simple investigations in this child. So there is clear evidence of an inflammatory process here. With the acute history and the symptoms we have, this is likely to be a septic arthritis. Okay? Another 3-year-old boy, 3 weeks history of limb. And in fact, initially he had pain and now progressively he's completely refusing to weight bear on that limb. So he's lost function of that limb. He's very irritable. He has some low-grade fever. He doesn't sleep well. He has a mild ankle swelling and he refuses you to handle that ankle at all. And look at his blood tests. Now, this child I would be very worried because these things, the child has lost function, is not able to sleep, is very irritable. And so let me look at the blood tests now. So the slight anemia, total count is normal, but look at that differential count. That's actually showing a relative lymphocytosis and a neutropenia. And look at the platelets. The platelets are actually low normal. And there is mild inflammation. This is a kind of scenario in which I would check an LDH. An LDH is one of the things of an LDH. It shows there is a big, strong marrow turnover. It reflects that. And the peripheral smear is normal in this child, but that does not put me off. With these symptoms, with this blood test, a normal peripheral smear doesn't matter. I would still go ahead and do a bone marrow before I do anything else to this child, as the diagnosis here is acute lymphoblastic leukemia. Really, the symptoms that give you the clue. Now look at this 3-year-old girl. She has a 9 months history of a progressive limp, and it is pronounced on waking up from sleep. However, when she wakes up in the morning, she cannot walk. She has a strong limp. She has no fever. She's otherwise completely well. And by mid-morning, she looks completely normal. Her knee has started swelling progressively, as you can see here. It's a nice swollen knee that she's got with a fixed flexion deformity. And her blood test, she also has a total count of 5.4 and an almost similar hemoglobin. But her differential is normal, her platelets are sterling, and it's the same. You look at the ESR and CRP, they are no different. But it's the symptoms and the thing that gives you the difference here. This is the child who has oligoarticular JIA, objective arthritis, chronic disease, morning stiffness. And here is a 3-year-old boy, 6 months history, he is unable to bear weight. And he is completely stopped walking. He has a mild fullness of his joints, but there are absolutely no other symptoms, except for the fact that he's very, very tender to touch. He's systemically well. He keeps his knees in the resting position and he completely refuses to bear weight, however you coax him. He has no systemic features. And look at, he has a mild anemia. His counts are all normal and very mild inflammation. And we did a lot of investigations on this child. And finally, it was a dietetic history that gave us the clue along with the X-ray. And what this child has was scurvy. So the thing is, extreme examination. And after that, you look at your blood tests. These are conditions that as general pediatricians, you will see a lot of, and none of these conditions need to be referred. So transient synovitis we've been through. The most important thing is make sure you're, just like in a febrile seizure, you want to make sure you don't miss pyogenic meningitis, so you have an alert in your mind. The transient synovitis, have an alert that you don't miss a septic arthritis or a malignancy. As we discussed this before, any child with joint pain who has bone pain, night pain, irritability, and functional loss, please think of it as red flag signs. The child I showed you with the malignancy, this is his X-ray. And you can look here at the metaphyseal area in both the ankles. This is called a metaphyseal lucent zone, and it is fairly pathognomonic of acute leukemia. About 40% of pediatric leukemia presents with musculoskeletal symptoms. And really, it's the red flag symptoms and signs that you need to be on alert for. Some children can present with all counts being low, but they can look, they can look normal as well and trick you. But look at the differential count, look at the actual platelet count, and don't expect that children with leukemia will have a high white blood cell count. Some do, but the majority in childhood actually have low counts. An LDH is a useful test. It is often based in these patients. Peripheral smear, if it picks up blast, is good. But remember that ALL particularly is a low count, low peripheral blast disease. So quite often you may not get a positive peripheral smear. And the child has enough features like this, the normal peripheral smear should not dissuade you from going ahead with a bone marrow. And be very careful, these children should never be given steroids because you can mask the disease. This is just to show you the X-ray of the child with scurvy. The pencil thin cortex, this is the Wimberger sign, and the submetaphyseal rarefactions that we noticed. And when we treated him, all this improved and he became completely normal. With 3 days of vitamin C, he started, his pain went away. With 3 weeks of vitamin C, he was walking. It was very, very satisfying to see that. So look at this child. If this child comes to your office, she's a very young child. She may not give you much symptoms. You may not elicit a history of morning stiffness, but you might elicit a history of this child being very uncooperative in the morning when she wakes up. But look at this. She has so many swollen little joints, which are all restricted. As well as her MCP joints, her wrists are swollen and restricted. And in the prayer sign, you can see the whole evidence of arthritis. You can see a restricted cervical spine. This is polyarthritis, polyarticular JIA most of the time. There are 2 peaks in children, one in young children and one in the teenagers. It's teenage peak, which is usually rheumatoid factor positive. A young child peak is usually rheumatoid factor negative. This is another very important sign. This is what we call enthesitis. You can see the Achilles tendon is actually swollen and it will be very tender. When this child is asked to walk on the heel, he will find it extremely difficult to do so. And you can see here, the ankle joint is normal. The ankle joint is easiest to examine from posterior. And often these children may also have an ankle arthritis, but this child has only enthesitis. So why is it important to pick up enthesitis? Because these are the children, especially if they are HLA-B27 positive, these are the children who go on later on to develop what we call juvenile ankylosing spondylitis. And this can be something that can be nipped in the bud earlier. So it's important to recognize that sign. Another thing that I think general pediatricians will see a lot of is reactive arthritis. So children who come looking otherwise well, but they have arthritis, this is often not chronic. This is often of acute or subacute duration. And this is basically an arthritis which develops soon after an infection elsewhere in the body, but you don't have the organism in the joint. This is the immunological reaction to the organism. So there are a huge number of organisms that can cause this, but one of our commonest culprits is the streptococcus. So here is one boy, he's 7 years old. He had a tonsillitis. 10 days later, he has a low-grade fever with an additive joint fear and swelling. He has early morning stiffness. Many joints are involved. He even has plantar enthesitis. He has significant inflammation. Now the problem is, This child can get labeled as an acute rheumatic fever, but he doesn't really fit Jones criteria. This is what we call post-streptococcal reactive arthritis. And this is a relatively subacute presentation or even acute presentation. An ASO titer is used to pick up the streptococcal background. This child responds beautifully to NSAIDs. Some very rarely you may need to use a small dose of steroids. And these children also do have a risk for valve damage if they have recurrent streptococcal infections. So it is useful to give them 1 to 1.5 years of penicillin prophylaxis. And basically, we have criteria to diagnose it. It's called IUD's criteria. And one of the important criteria is failure to fulfill the modified Jones criteria for rheumatic fever. So here is another girl, however, this is the difference. This child is sick looking, high grade fever with a migrating arthritis as described here. And she had a pharyngitis 3 weeks ago and she has significant inflammation. This is acute rheumatic fever. This presentation is quite different from the one I showed you before. And let me tell you, in today's world, in India, acute, especially in Kerala, acute rheumatic fever is not common. It is less common than JIA. It is less common than many other conditions. So we should be quite careful before we just, prescribe penicillin prophylaxis and do ASOs repeatedly. It is definitely the incidence of this condition has come down. And this brings me to another thing. ASO titer is not really a diagnostic test. It has a supportive value in the diagnosis of immunological arthritis following streptococcal infections. But otherwise, somebody who has some joint pain and who has high ASO, especially if that is going on for years and years, the ASO has got no value at all in this diagnosis. Okay? There is absolutely no value in repeating ASO subsequently, and no value in doing an ASO in somebody who has chronic joint symptoms, as seen in this particular child. So this is something we need to be wary about. Another very, very common condition is hypermobility. This is again something general pediatricians can pick up. These children usually, it's actually a common condition, especially in children. 10 to 15% of children can have generalized hypermobility. And usually what happens is when they are very active, when they played games, they've gone for dance classes, they've gone for sports practice, they generally tend to have quite severe pain in the evening, and it improves beautifully with rest. If you do the Beighton score, which I'll show you in a minute, you will find then the little finger, the hyperextended elbow, and the hyperextended knee. And you can see there is one child of mine who's fulfilling all this. Sadly, this child was actually diagnosed as JI and was on methotrexate when she came to see me, and I could stop all her medications. Now, this is another thing that often foxes people: tuberculosis and arthritis. You know, often TB in children, especially osteoarticular TB in children, primary osteoarticular TB is not common. Arthritis related to TB is more often a hypersensitivity disease or an immunological disease, what we call Ponson's disease, especially when it's symmetrical, bilateral, like you see in this boy. And primary osteoarticular TB, where you can get the organism from the joint, is not really that common. It does happen, but it's not that common. This is a child who came to me as a young child, was a 3 or 4 year old, who came to me as an oligoarthritis. And she even had a synovial biopsy, which was very non-specific. Her synovial fluid did not grow anything. And so I thought she's a JIA, oligoarticular, injected her and sent her off. She came back after some time and she has this new swelling, which is actually in the muscular compartment, but looked like it was corresponding with the joint. I sent it to the pediatric surgeon, and we found out that what this child had was actually a cold abscess due to atypical mycobacteria. This is another boy who I thought could have been sarcoidosis. 9 months history of an oligoarthritis of both elbow joints with significant restriction. And however, my standard workup always involves Bantu and chest X-ray, and he even had a uveitis. And this boy had an ulcerating mantle. You can see a large lymph node, which we biopsied, that was positive for tuberculosis. And his uveitis was also TB. And we were able to treat him with ATT and get him better. And you can see after ATT, he is much better. It's important that when you suspect TB, just a mantle positivity is not enough to make a diagnosis. You need to go in a bit harder. So a lymph node biopsy, synovial biopsy, if you're doing, it's not enough just to do a histopathology. Please save a second sample for culture that has to be preserved in saline and cultured along with a gene expert. Growing pains are very common. Every pediatrician must be seeing one probably every day. And this is a very nice condition. The parents are very, very alarmed, and you can reassure them, send them home in just a simple consultation. The important thing is it is non-articular pain, usually in the high growing age, and it happens late in the day, nocturnal, usually at the time of sleeping or just after they've gone to sleep. It has to be differentiated from the nocturnal pain of a malignancy. And I'm sure if you ask a few more questions, it's not going to be difficult to miss that. So that was about children with joint pain. The other situation in which you must think rheumatology is when you have a child with prolonged fever, especially if a child with prolonged fever also has multisystem disease. So 20% of PUO causes are rheumatological. And its history, the clinical findings, a multisystem assessment that is required. Once again, pattern recognition. And there are many things here: systemic onset JIA, connective tissue disease, is it vasculitis, are they periodic fevers? So there are many things that we need to do. So we need to take a detailed history examination before we decide how we progress. So this is a child who has a prolonged fever, quotidian pattern, almost the same time every day. Very high fever, often accompanied by an evanescent rash. It's so convenient when this evanescent rash is there. When it's not there, it makes the situation more difficult. Many of them also have lymphadenopathy, hepatosplenomegaly, or serositis. And when you start treatment, the right treatment, they won't respond to antibiotics. They won't respond to many other things. All their infection screen will be negative. But you start treatment, which is either NSAIDs initially. If it's not responding, steroids, you'll find that they respond beautifully. Now, every quotidian fever should make you think about systemic onset JIA, but that is a diagnosis of exclusion. So, which means again, you have to have your suspicious antennae up all the time. So this is a young 2.5-year-old, 3.5 weeks of fever, which is very well between the spikes. And she had a mild limp also of the left lower limb. There was no obvious arthritis, but she had a limp which was notable when she was walking. There was no other feature to make me think about systemic onset JIA. Her CRP, ESR were very high, and her counts were very high. And so initially they thought she was Kawasaki. So even before I got to see her, she was given IVIG. There was absolutely no response. There were, even after 3.5 weeks, the coronaries were completely normal. So that, and she had no other features of Kawasaki either. And she had already undergone a bone marrow and a lymph node biopsy by the time I saw her. All of it was negative. So I was really suspicious about this girl. So what I said is, let us look for internal pus collection. So we did a CT chest and abdomen. And here it was a large ileoceous collection. And that was probably why she had the lymph as well. And she got better. So deep infections are also something that can trick us. And that is why, the clinical acumen, to having a high index of suspicion is very important. Childhood onset lupus. When will you think of lupus? 20% of SLE starts in childhood. So you really have to have, it's very unusual under 5 years. But it can happen any time after that. And usually around puberty, have the maximum incidence of onset of lupus. If the rash is present, it's often picked up. Many children may not, in our series, about 40 to 50% of children do not have classic rash, and many do not have any rash at all at the point of diagnosis. Children tend to have more severe systemic involvement and require more aggressive treatment. It's really important we pick up these children early. So when you have a child who is, sometimes they can be non-specifically unwell with non-specifically not completely normal blood tests either. But then if you look further, you'll start finding some rashes, arthritis, loss of appetite, loss of weight, oral ulcer, muscle weakness, etc. And it's actually trying to pick up the multi-system element that is important. Can you hear me? Low counts, especially a lymphopenia. As we discussed with malignancy, SLE patients can also present with low counts, but lymphopenia is what you look for in this case. They may have other autoimmune diseases. So again, it is about having a high index of suspicion. So not all children, see, this is a child who presented febrile, unwell, with a very severe rash. This is a child who actually had seizures and encephalopathy, but has no rash except for some ulcers on the lips. This is a child who has oral ulcer in the palate. This is a pathognomonic sign of lupus. If this is something can be asymptomatic, you have to look inside the mouth and look at the palate to pick up the sign. Some children can have such a florid rash, as you can see, the body is covered. This is another one where they present with muscle weakness and these kind of rashes. This is juvenile dermatomyositis, and you have to examine the child. Again, this is pattern recognition, skin changes, muscle weakness, elevated muscle enzymes, and classic juvenile dermatomyositis. I'll give you some clues later. This one again, it's so easy if this patient has all these features. Nobody will miss. The problem is that they go with fever, which is not improving. So the parents keep changing doctors. So the first doctor will see fever with conjunctivitis. The second doctor will see fever with red lips or tongue or something. Another doctor will see fever with lymphadenopathy. Another doctor will see fever with rash. So unless you take a careful history and ask all these questions, you will miss the classic signs and you will miss the diagnosis early. The other problem is using other NSAIDs for fever round the clock in children who where you haven't really got a focus. Sometimes it can mask the problem. It can actually reduce the fever without reduce the inflammation. So again, it's a thing to have a high index of suspicion. And of course, keep your ear out for atypical presentations. Kawasaki, the earlier you pick up, and the very important thing is also, it's not just enough to pick up Kawasaki. These days, we're trying to pass the message that at the time of diagnosis, please assess the risk, the CAA risk or the IVIG resistance risk of this child, and go for an intensified regimen of treatment upfront for many children. This can help to really reduce the long-term coronary outcomes. At this point, I must say, remind you once more about the new disease alert, post-COVID inflammatory multisystem disease that we are seeing. They are presenting, some are presenting like Kawasaki, some are presenting like toxic shock, some are presenting like macrophage activation. We've already started seeing cases in different parts of India. All of us need to be alert. These children respond beautifully to treatment if they are picked up early, but they have to be treated. We also have to think about doing other tests, serum ferritin, NT-proBNP if it's accessible, and getting echoes in these patients. Another condition that commonly presents to pediatricians. So a child with a dark skinned and a fair skinned child that presents with this kind of rash. When they have this rash, there is no mystery. This is HSP. It's not difficult at all to pick up. There are other features too, other than the rash. They can have peripheral edema. It's very painful. It's confused as arthritis. This child has arthritis, but actually has peripheral edema, just like you see in Kawasaki. This child had the purpura in the palate as well, and peripheral edema on the hands. It's very, very painful. So what happens, however, if they present without a significant rash? So children don't read the book, especially young children can present with just abdominal pain and vomiting and get admitted under pediatric surgeons. And often they can even go for laparotomies, which is a sad thing. So the clue should be any child presenting with abdominal pain and vomiting, with colicky intermittent abdominal pain, naturally every one of them will have an ultrasound at the bare minimum. So when they have an ultrasound, when you're seeing multiple levels of bowel thickening and edema, you should have suspicion whether this is HSP. They may or may not have interception. See, most of the other causes of abdominal pain, acute abdominal pain in children, will not have multiple levels of bowel thickening and edema. And when you see these children, it's important that you go back, because surgeons will not look for rashes. We have to go back and look. I had a whole series of young children under 5 years, all present in the same month, just like this, as acute abdomen under the surgeons. The radiologist does the scan, ask them to, could this be vasculitis? So they call me. I go see the child, just 1 or 2 purpurae. And this is a situation where I will do a skin biopsy and start them on steroids straight away. So you can avoid a laparotomy. And that is what is important, because if you miss the diagnosis, you can have very serious outcomes. And this is, we know, the diagnostic criteria for HSP. HSP-like condition can present in very young children. It looks very dramatic and very scary. I've had pediatricians get so scared by the sight of this that they send the child straight away. Please have a look today itself. This is one of these things that looks far worse than it is. So you can see this child, he has some fever, he has a purpuric rash, large, almost coin-shaped lesions with mild elevated markers, a little bit of changes in the urine and peripheral edema. And sometimes it can be this dramatic, actually, when they present all this very, very severe rashes. This is acute hemorrhagic edema of infancy. It's like a HSP prototype, which happens in very young children. And there are specific changes in the biopsy of these children compared to HSP. However, this is even milder than HSP as a disease and responds often beautifully to NSAIDs, and the outcome is even better for these children. When you see a child presenting with recurrent large oral ulcers, plus or minus large genital ulcers, please think of Behçet's disease. Especially Kasargod, Kannur, Calicut, your area, you're part of the old Mediterranean Silk Route, and there are a lot of patients in this area. And what about these children? So this is, again, something that pediatricians will come across in plenty. Lots of symptoms and no signs at all. Very dramatic, very, very, worrying, upsetting for the family. The child often misses school, and you look at the child, they don't look sick at all, but they have very dramatic symptoms. So severe pain in the left upper limb, keeps the hand permanently in that position. But when you examine the child objectively, you can actually move the joint beautifully. There are no major problems. There are changes, autonomic changes of a chronic pain syndrome can be present, but there will be a significant discrepancy between subjective and objective examination. And actually, this is the worst thing you can do to these patients. Of course, to make a diagnosis of chronic pain, you will need to do blood tests, you will need to do some things to make sure you're not missing anything major. But please trust your clinical instincts. If your child has only symptoms and no signs, if your child has absolutely no corroboration for so many such symptoms in the investigations that you're doing, then don't be driven to find a disease here. And the most important thing is not to feed the disease with extra supports like splints and casts and medications and whatnot. So these are chronic pain syndromes. Often they have something called allodynia, which is basically very disproportionate level of pain for a particular stimulus. This is a bizarre symptomatology that doesn't add up. And these children require some time from you. Sit down and take lots of questions. You know, this particular child, the reason she used to do this every time her father came home. Her father was a lorry driver. When he came home, he used to get drunk and beat up her mother. And if she faked a pain, then all attention would be turned to this and the mother would be left alone. And that's why she did it. So, you know, if we refer these patients to orthopedic surgeons and if we don't refer them to psychology, if we don't do a family therapy for this child, you're never going to improve the problem. And the secondary gain is the first thing that needs to be shut down for these patients. These conditions are very common, very, very common. I see at least 1 to 2 a week. So you all must be seeing far more, I think. So it's really important that we do justice to these children. So what do we do when we have children with long-term disease, chronic disease? So the management often, especially something like JI, you want to initially relieve the pain, prevent deformity, etc. But in the long term, you want to both control disease and promote normal growth and development on the least possible level of drugs that they can have. So I'm being very, very fleeting with treatments because I think you know the purpose of how we treat a condition like JIA, for instance, is we use NSAIDs or steroids in the beginning to actually induce remission. But the main remission is carried out by DMARDs. DMARDs are the only drugs that actually work at the immunological level and actually prevent this condition from getting worse and cause a remission and prevent deformity in these patients. If you keep them on only naproxen or steroids forever and ever, they will not get better. They will only get the side effects of those medications. They will land up with a lot of deformity. And steroids in JIA, we prefer to use very intra-articular if possible, bridging dose, small dose along with the DMARDs for the first 2-3 months. And only if there are systemic features, I would use high-dose IV steroids. Try not to use high-dose IV steroids in most cases of JIA. And it's the earlier you start DMARD, some children require biologics, earlier you do that you get the best outcome. Now let's look at investigations. This is again a very, very important thing. I think clinical history and examination really give you a lot of information. You know whether you're dealing with something significant or not here. Now your baseline tests are only going to add what you already suspected through this. So what are the various patterns you can get on account? That classic inflammation pattern is anemia, leukocytosis, and thrombocytosis. But if you have anemia, leukopenia, low platelets, think of either malignancy or SLE or macrophage activation. If you can very well have patients with JIA, patients with HSP, and several conditions who have completely normal counts. So the normal count should not take you away from that diagnosis. ESR and CRP, both can be raised in significant inflammation. However, in many patients with JIA, especially oligoarticular JIA, it can be completely normal as well. When you have a child with a low ESR and an elevated CRP, it is macrophage activation that is happening here, a HLH process. When you have a raised ESR and a low CRP, think about active SLE. Because unless there is arthritis or serositis or secondary bacterial infection, CRP is not elevated in lupus. The serum ferritin is a very useful test in systemic onset JIA. When you see patients with musculoskeletal symptoms or fever who present with raised SGOT, SGPT, don't always assume that it is a liver disease. Of course, these are liver enzymes and they can represent liver injury or liver inflammation, which can also be found in macrophage activation. But do remember, they're also muscle derived enzymes. And if you suspect muscle derived, do an LDH and CRP, they will also be extremely elevated in the same patients. Similarly, serum complements, if they are low, it's very, very important to consider the possibility of SLE. Specific investigations, we've already discussed the ASO titer and how little use it actually has in real life. Rheumatoid factor is positive only in 5 to 10% of JIA. The place of anti-CCP in JIA is minuscule. We would only do it if we had a typical polyarticular JIA, especially in an older child who might be rheumatoid factor negative. In that case, I might do an anti-CCP. ANA positivity is important, but please don't do ELISA ANAs. The degree of unreliability is very high. Please do ANAs only by immunofluorescence. Remember, ANA is not done to rule out lupus. When you have a child with the kind of examples I showed you, the clinical prototype of lupus, an ANA test is useful to add to your diagnosis. ANA can also be positive in oligoarticular or young polyarticular JIA, which shows an increased risk for uveitis. It can be positive in other autoimmune diseases. It can be raised with, as an immunological response to infections, especially mycoplasma and all. And it can also be false positive in normal people. So just an ANA positivity doesn't mean the child has any illness at all, unless there is clinical paradigm to go with it. HLA-B27. If you see a child with JIA, don't do ANA, rheumatoid factor, HLA-B27 on everybody. Only a bunch who present like enthesitis-related arthritis need a HLA-B27. And none of these tests are actually used for ANA in lupus, yes, is used for diagnosis. But in JIA, none of these investigations are diagnosis. The definition of JIA does not have a single blood test. They are all useful for subtyping and for prognostication. Positive serology alone does not make a diagnosis. It is pattern recognition and fitting your tests into it that is important. For the same reason, I dislike vasculitis screenings. So these are some common misconceptions. We see ASO titer and give them penedural prophylaxis for life. There is often no indication for that. A single swollen joint, we think it must be TB and give them ATT, but then they develop limb length discrepancies and fixed flexion deformities and blinding uveitis because we missed the JIA. Lack of regular eye checkup for uveitis. I've seen it so many times. Normal blood tests, hence there cannot be any JIA. That's also a misconception. Too much reliance on blood tests. And another bugbear of mine, I have nothing against orthopedic surgeons or other surgeons. I'm actually married to an orthopedic surgeon. But with pediatric, most of these conditions are medically managed and they are not orthopedically managed conditions. So we really need to have this reflex. We should know why we want to refer a child to an orthopedic surgeon. He can rule out fractures, he can rule out osteochondritis, he can rule out avascular necrosis, conditions like that. But or maybe pick up a septic arthritis. But don't expect an orthopedic surgeon to diagnose JIA, to diagnose many of the other conditions. And the worst thing is that some of them start these children on steroids. And I've seen so many children with malignancy, unfortunately started on steroids by orthopedic surgeons, delaying the diagnosis. So I think we need to know, this is a very important point as general pediatricians, that child, you are seeing, you have the custody, you need to do the best for that child and who's the best person to send to and what are the conditions to think about. Similarly, all abdominal pain to pediatric surgery, their view, their opinion, this thing is extremely important. But please do remember those children with HSP. Look for them yourself. X-rays, radiology. X-rays have very little to help us with diagnosis of JIA. Ultrasound can help very much in picking up synovitis, especially in deep joints. MRI is extremely useful for sacroiliitis and for defining infections, like I showed you earlier. Synovial biopsies, we do not routinely do in children. The pathologies in adults and childhood are very different. Most of the time, we don't need to do routine synovial fluid aspiration in children. Gout is hardly ever seen in children, but it has a role in monoarthritis if you suspect TB. And it's important that for TB, we always culture for TB. Similarly, when you have connective tissue disease, etc., vasculitis, the workup involves in the clinical examination, relevant blood tests, the relevant serology, imaging, and biopsy as required. So we've been through this. And so role of the general pediatrician is suspect, high index of suspicion, refer early, and I strongly believe in shared care. I believe that if the patient comes to me for care for a pediatric rheumatological disease, they should go back to their primary pediatrician who has a huge role to play. Intercurrent infections, immunizations, the disease management and follow-up can be done by me. But all their other problems, they need you. And it is best that any issues are liaised between yourself and the tertiary specialist, because the findings can be much more objectively given. The problem can be much better understood. And if for the family as well, it reinforces a sense of trust between the patient and family. As a thumb rule, we say that many of the medications our children are on, we would not want them to have live vaccines. Thankfully, the majority of children develop pediatric rheumatological diseases after most of the primary immunization is over. But the ones who develop earlier than that, we still do not give live vaccines if they're on high-dose steroids, biologics, etc. But definitely we want to encourage that they complete all the killed vaccines. A prompt management of chickenpox is very important. Most children on immunosuppression can have serious chickenpox. So acyclovir from day one is very, very important. And it's shared care and combined approach that can give us the best outcomes. So look at the clinical scenario. The symptom does not create diagnosis, but symptom plus clinical examination plus pattern recognition is what is important. And please include PGALS in your regular workup of patients. Thank you. I'll take questions now. Thank you for your patient hearing.
Thank you very much, madam.